Thank you for the introduction, Stephanie. I am a geriatrician and a palliative care doctor. My passion is dementia. I was in academic medicine for about 30 years, and have semi-retired, and since then been trying to write books about end-of-life care and dementia, because when my family, I was the care partner to my mother who lived with dementia and my siblings, and we all tried to support her in her journey, living well with dementia for quite a bit of time, and then finally dying from dementia. And when she transitioned to that dying from dementia, I had a hard time finding resources that were helpful to my family. And so after she died, um, part of what I wanted to do is try to give back a bit in that way, so that other people didn't have as much trouble kind of navigating that part of the journey. I don't know if there's more. I don't think there's more you need to know about me. I love working with CaringKind. I think they do amazing work, and I'm very honored to be here tonight to speak with you. So this will be part two, in understanding the person-centered approach to the dementia journey. And tonight we're going to talk more about planning our care choices and our actions. And I'm going to try not to make as many mistakes as I did last week on forwarding the slides. So I think that the first transition we need to make in tonight's work is our willingness to consider the end, learning about that late stage, but with the idea that there's hope for improving current living. I don't want us just thinking about the transition to late stages just to think about it, but it's to help us live better now. And what we do know is that people fear the end of the life living with dementia. And most people in a study they've shown that people think about that dependence and they have that fear of the physical and cognitive decline. Yet they expect the doctor to talk to them about it. They don't think that they should be bringing it up. In another study, 75% of hospitalized patients thought about their desired care and discussed it with their family most of the time, but less than a third talked about what they really wanted with the healthcare team. And in yet another study, about 92% of people over 50 who were considering end-of-life care spoke to their families a bit, but only 18% spoke to their doctor about it. So while people worry about it, fear it, think about it, it's obviously in their mind and in their thoughts, they're not necessarily communicating those fears, those concerns, or those wishes with the people that need to know them. And here's where I'm going to see if I learned my lesson. I did. And so if you were with us last week, I did talk about having conversations and facing some of these more difficult conversations. And I think we need to be able to think about death. And we often don't think about things that scare us or places we think are uncomfortable. And so I think I'd like to start the talk about maybe we could take a little bit of time and think about what are some of the positives about death. And then maybe that will take some of the sting out of it. Maybe we can get to a place where we're like, oh, it's something to think about. It's not something to fear or resist. And I've put several positive aspects of death that were brought up in a book, How to Get the Death You Want by John Abram. But there are things like the positives can be that it reminds us of our common human condition. We know that death literally gives us life. Whether you eat animals or you eat plants, those things are there to sustain us and to nourish us. Death enables evolution. We change and grow, and we continue to change and grow as species as we evolve. And that's partly through living and then dying. All these things, I mean, death can bring an end to suffering. That's one that we hear a lot in the medical field, because sometimes there are some things worse than death, and the suffering of some medical conditions can make it so that death is a welcome relief. And so I think if we think, oh, death isn't all bad, we have a chance to actually bring it up and talk about it. And I would like you, I mean, I think that's part of tonight's homework will be to begin these dialogues about death. But before we ask others to talk about death with us, we need to kind of understand where we're coming from, and think about, like, sometimes I think of this as people going into their own dark corners, because we need to look at the whole picture. Like, when I was contemplating my mother's death, um, there were times that I thought, oh, I'm reconciled and I'm prepared for this. There's other times that I was thinking of it as a tragic event. Other times I was looking forward to it in a way, because there would be a release and a relief that her suffering would be over. And I can say that in the healthcare system, physicians often think of death as a defeat, as something to be avoided. And that when a death occurs, that's a failure, which is why I think often the healthcare system isn't coming forward to speak about death, because that's not their goal necessarily, or that's not how most healthcare providers have been trained. And so if you want something other than the healthcare system's approach to death, um, most likely we're going to need to start talking about these conversations. And from a societal standpoint, we are very reluctant to talk about death. There's the see no evil, hear no evil, speak no evil, and people think of death as evil. I mean, the picture of the Grim Reaper. And while death isn't very common, probably as a Scrabble word, it could be a Wordle word. Not a great one, not a bad one though. A lot of the common letters, but these are not places we like to go. And so I want to bring up that if we avoid talking about death, there are some pretty big consequences. We probably should get it into our vernacular. There's some of the reasons are, if we don't address it, we will be not prepared when the time comes. I understand that sometimes things happen unexpectedly, but when you're living with a chronic condition, whether it be cognitive loss or heart failure or something, you will be served better in the here and now, if you start to address some of the things that need to be addressed, whether that be coming up with a durable power of attorney to help you make decisions in the event that you can't make your wishes be known down the road, whether that's planning for a funeral, whether that is preparing fiscally for what might be coming. The emotional and psychological toll of avoiding planning is devastating. When you look at studies about people who are care partners to people with a terminal illness, it's more than a third are devastated by the ultimate loss. And this is in people who have known terminal disease. And that puts the people left behind at high risk for poor grieving. There's much more likely to have anxiety and depression and prolonged and complicated grief if you don't kind of get ready for that death, if you're not prepared for it coming. And people actually feel like they were traumatized by deaths when they're not psychologically and emotionally prepared. The third, I think, big reason we shouldn't avoid talking about death and beginning to plan for it is that we end up with unneeded and unwanted medical interventions. In one study through the Harvard School of Public Health, they said that 1 in 10 Medicare recipients had an operation in their last year of life. No, 1 in 3. 1 in 3 in their last year of life. 1 in 5 in their last month of life, and 1 in 3 in their last week of life. So that's a lot of interventions that were probably done because we often do many things or almost everything. And so recovering from surgery may not be the way you want to finish, or if you're near the end of your life, recovering from surgery may not be the way you want to spend your time. And finally, and I know I talked about hospice and palliative care a lot in the last talk, but you're going to miss out on those available supports if you're not thinking ahead and planning ahead. Um, about 40% of people only have hospice for about 3 weeks to just a few days. And those numbers are far too small. That extra layer of support can be huge to the person living and dying so that they have a more comfortable death, and for the people who are left behind to have the support of a team of people who know about living and dying. So I'm fairly practical. So what is a practical framework to help us start thinking about when is it the right time to start talking about death? And the spoiler alert, in my opinion, is it's always the right time. These need to be small and frequent discussions, because a one and done is not going to do it. Things continue to change. We evolve in our thinking. The more comfortable we get with approaching something, um, we need to keep talking about it. I have a dear friend whose father-in-law had heart failure, and um, she was his power of attorney, and she called him father-in-law, and he called her daughter-in-law. And every time he was hospitalized, or every time he had a shift in his medical conditions, she'd say, "Father-in-law, I know you've told me this before, but have you evolved in your thinking? Have you changed what you want?" And he would confirm with her that he still wanted things, or because of the last hospitalization, or because of a change in his function, he wanted something different. And I think that as my mom was living through her dementia, she did change some of her thinking. We had frequent conversations to keep the ball rolling on what she wanted. And so if you're wondering if it's the right time, I say yes. If you think Anne's a little odd and she might talk about this a little too much, know the disease, ask your team, do some simple research to look for the progression, and hope. I mean, we're trying to offer some of that here at CaringKind, but if you forget what we say, or you don't go back to our recordings, do a little bit of research and see. And finally, trust your intuition. If you're honest with yourself, when it's time to talk about something, when it's time to bring it up. And often communication, if it's difficult, it's still worth it. You can do hard things. I know you can. We're all doing hard things every day. And this matters. These are important, maybe difficult, but important conversations. And so I showed this on our last talk and I'm going to show it again in this talk down the road. But I want us to remember that we have goals of care, and they may change as the disease changes. And so dementia, as we know, is a chronic disease, very long, and changes over time. So the goals may change over time. In the beginning, one may want to do most everything. As things change, people may still want to do everything. In fact, studies have shown that about 10% of people want everything done, whether they're in early stages of disease, moderate stages of disease, or late stages of disease. And that is fine. 10% of people should have everything done then. But another 60% want much more comfort at the end, only comfort. And then about 30% want something in the middle. So as you can see in this progression, there are so many choices of how things can be modified. And tonight we'll talk about some of those things that can be modified if you want them to be modified. And but I want to bring them up so that they're top of mind for you, so that you can bring them up to your healthcare team, your support team, to the person that you're supporting, to the person that's supporting you, depending on if you're the person living with dementia, living with cognitive loss, or you're the one supporting someone living with cognitive loss. There's a lot of choices, and these are not the things that make it onto advanced directives necessarily. These are the more nuanced aspects of making the choices in this continuum. So I'm going to just go through the Kenny family story a little bit. I do this a lot. I think I talk about my family a lot because I think we were pretty typical. We had our ups and downs, we had our ins and outs, but I'm looking back at it now, and I have the luxury of 2020, and I have the luxury of seeing many other families go through this and partnering with them. And so I can kind of do a little amalgam of my family and the common things that came up for us that I know are very common for many other people. So when my mom was first diagnosed with dementia, her goal was to be as independent as she could for as long as possible. She wanted to live at home as long as she could. And so she did. She lived at home with some supports. You know, we tried to make sure that when she had issues or questions, we were there for her, but she wanted to handle it herself. She did very well. There's a point when because of her cognitive loss, she actually lost her sense of smell, which is not uncommon, and she could not figure out that some of her food was going bad, and started going to the emergency room quite a bit with abdominal pain because she was eating bad food. We also noticed about that same time that she wasn't able to keep up with her medications. And her second husband was having cognitive loss and actually having other medical illnesses, and his family had him go to a long-term care facility. So she went from living with someone else to living alone. And at that point, it made sense for her to transition to something with a little more support, mostly for that medication and for the eating. She was in assisted living, but not dementia specific. She was doing great, having a great time, and her disease started to progress a bit more, and she wasn't thriving in that independence any longer. So changes were made. We went and added a day program and started putting more supports around her dressing, made her dressing much easier for her to handle independently, and then had a few more checks and balances. She did fairly well like that for a relatively long period of time, but then she had a medical complication. She had a stroke. And at that point, we knew that she was beginning to go from living well with dementia to starting to die from dementia, that this stroke took a big functional hit for her, took her language, and took some more of her cognitive abilities. And at that point, she moved closer to me. At that point, she needed a more dementia-specific assisted living. We talked about having her live with my family, but her social needs were still so high that living with my family would have been too narrow for her. She needed a crowd. She needed friends. She didn't want to just hang out with my little kids or me going to work every day and one other person. So she lived well in that way. At that point, though, we started to take away some medications that we thought we were going to potentially prolong her life and get in the way of dying from dementia. And what we found is when we took some of those medications away, she got better. She was living with complications we didn't know about. And when those medicines were taken away, she did much better. She still did quite a bit of exercise. She still needed quite a bit of engagement, but we did less medical intervention. And at that point, we also talked about no more hospitalizations, that the hospitalization was pretty traumatic on her. And we thought if we can handle it without hospitalizations, we're going to. She lived that way pretty well until she started to have difficulty with swallowing and not able to successfully swallow her food all the time and had her first bout of pneumonia. And at her first bout of pneumonia, we got hospice involved. They helped me keep her out of the hospital, but comfortable. And from then on, she lived for 2 more years with more and more loss in her function, several bouts of pneumonia, changes in my nutritional goals for her, which were based on her nutritional goals for herself. She lived on ice cream for about 6 months before she closed her mouth completely to food and chose to leave this planet by not wanting to eat. And it was a choice, because when we tried to put food in her mouth, she would give me this look I knew from my childhood very well, like, "Don't you dare, young lady, don't you dare." And so my job then was to go to her assisted living and help support the aides, in that feeding her was not the way to support her, that supporting her in other ways, loving her in other ways, was the way we were going to let her leave this planet. And so that's our journey. That's how we changed the interventions as my mom went through her journey, with her goals in mind. First independence, then socialization, then less the right thing, less fruits and vegetables and more ice cream, and finally honoring her wish not to let anyone put food in her mouth. And that's kind of our journey. And it's not dissimilar to many other people's journey. But I can also imagine that other people may have had their parent go to, or their family member go to a hospital more until they realize the hospital is not helping them anymore. Things like that. These are the kinds of things we're going to talk about tonight. So now I want to kind of transition the talk to not just my journey, but a study that kind of goes over what a lot of people, both living with dementia and their care partners, think about the issues around these end-of-life choices. This is a study done where they took about 2,600 papers and they culled through them, this has the voices of about 400 people living with cognitive loss and about 1,600 care partners. And they got 5 themes, and these are the themes, and I'm going to go through them one by one. The first theme that came out of this study of people living with cognitive loss, or supporting people living with cognitive loss, says that one of the biggest concerns is avoiding dehumanizing treatment and care. And what people said is they want to remain connected. They want to have spiritual connections. They want to have physical connections. They want to have social connections, just like everyone else. And they don't want the cognitive loss to get in the way of that. They want to delay institutionalization if possible, and they want to reject the burdens of futile treatment. And I think my mom's story kind of highlights many of these points, and many other people do as well. They want to know that their humanity is number one. And so after we go through each of these, I want to stop and do a little contemplation. What in your family, you or the person you're supporting, what would it mean to them to remain connected? For my mom, she needed a lot of social time, but as she got further in her disease, she needed rest. But when she was awake, she needed to be social. So the aides at her facility would often call me because she was only awake a few hours. And she lived right behind where I worked and very close to my home. And so I flexed my time near the end of her life so that when she was awake, I was over and making sure she went to the activities, or that we sat with 3 or 4 of her friends. And that's how she remained connected. And she was severely impaired. Her communication, she had little communication, but I knew from her, from my lifetime with her, but also from her, because she actually communicated very well with her eyebrows. And if you paid attention, she was communicating quite well nonverbally. And so we worked on that a lot to make sure that communication came through. And everybody has a different feel of what is dehumanizing to them. And to know that, to have discussions about that is probably important, because what's dehumanizing to me, I mean, I had these conversations with my siblings because I wanted them to kind of reflect on their own what matters, so that we weren't judging each other when we tried to choose what my mother wanted. One brother definitely wouldn't want very much hands-on at the end of his life at all. And he made that clear, and actually died a few years ago, and probably went on hospice much sooner than the doctors wanted him to. They probably wanted him to go through one more treatment, but he was clear that's not what he wanted. Another brother thinks he's probably in that 10% that wants everything done as long as possible. So in my family, that could have been a huge struggle, because two brothers had these hugely polarly opposite opinions, and the rest of my siblings, there's 6 of us total, were somewhere in the middle. We needed to know what was dehumanizing for each of us, and then I and my mom had this conversation, so I could say, but this is where mom's line is, and so we all would honor each other's lines. Uh-oh, something popped up. It's not letting me do it. I think I got it. All right. The next thing is confronting those emotionally difficult conversations. When I read this paper and I found out that people thought that talking about death causes death, I was shocked. I had never heard that. I come from the Midwest. I'm from the city part, but there's a lot of farm philosophy, and there's life and death all over the place. I was very surprised about this. And there's ways around, again, I think there's ways to start talking about death. We've talked about maybe looking at some of the positives. There's something called death over dinner. That's a way that you might get people to start talking about death a bit. It's the brainchild of a man named Michael Hebb, who is a restaurateur and a provocateur, basically. And he's found that he thinks over dinner and libations, we can probably talk about this. And he's curated videos and readings and poems and and arts with themes, that you can host dinners where you talk about death, because talking about death doesn't cause death, or I'd already be dead. A lot of people feel that the cognitive decline is too frightening to think about in advance, and for those people, when I see them in my clinical practice, I ask them to just think one step ahead at first. And, in time, when you shine lights on things, they're not as scary. And finally, people felt that having these difficult conversations, if you then had to do an advance directive and tick a box, they were afraid they were too locked into that, which brings me back to the father-in-law, daughter-in-law conversation. If you make an advance directive, you can, it's more the conversations with other people. The advance directives need to be, they need to be written, but they're just a piece, and things can change. So again, in the things to contemplate, what would facilitate these conversations? If you know your family, you know the landmines and the soft landings. So how can you get through and make some of these conversations happen? Are there any tools that can help you? Death over dinner being one, a death cafe being another. There's a couple of games called Go Fish or Go Wish, which is like Go Fish, but it's a game, and another one called Hello, that try to bring these. It's like a card game that helps bring up some of these conversation starters. Those are things to consider. The next of the 5 themes is navigating existential tension. And this is something we were talking about at the beginning. We don't like the difficult things necessarily, but it is part of life, and we do usually accept the inevitable incapacity and death. And what can help us with some of that? Whether that be a spiritual guide, somebody in a religion, a therapist. But if we're having trouble in that area, there are people who this is what they think about, philosophers, writings. There's ways to kind of dip your toe in here and get through it a little more easily. Care partners often are fearing being responsible for death, but I say that the more we talk about it, the more you realize you're not going to be responsible. You're going to just be honoring people's wishes. And again, alleviating that decisional responsibility comes from these conversations. So again, on this, what can help you tolerate existential tension? Support groups, therapists, spiritual leaders, um, poetry, works of philosophers, all kinds of things. And what can be started or improved to help you get through the existential tensions of living and dying in on the planet Earth. The fourth of the themes was defining personal autonomy. Care partners struggle with unknown preferences. So again, I think conversations will get us around that, if conversations can be had. And then individuals who are living with cognitive loss were worried about having to depend on care partner advocacy. And so people, I can say that I've had several people where they've said their wishes, and family members might say, let's not talk about that. I don't want, you're not going anywhere. I don't want to talk about that now. And that can be very off-putting for the person who's trying to get their wishes known. So I ask that sometimes, again, that existential tension is held, but that the voice of the individual who's trying to communicate and asking for your advocacy be heard. And finally, that justifying treatments when they're in the face of health deterioration. There's going to be a lot of push-pull around this. Are you doing too little? Are you doing too much? You're going to be getting different opinions from all kinds of people. So go with your goals, your values, figure out what you want as you're in this, and then realize that people are going to differ in what they think. And in my family, what we said is, we put a lot of thought into this. I really appreciate your input, but these are complicated decisions, and we feel comfortable with the decision we've made. We said that to healthcare providers. We said that to extended family members, because not everybody agreed with what my mom wanted. But we didn't need to get in a fight with anybody. We just wanted to say, yeah, we hear you. We thought about it, and this is what we want. So ask for what you need. Help the person you're supporting. Ask for what they need. Help the person who's supporting you help you ask for what you need from healthcare, from other family members, or from other advocates. But everyone, it's nice if everyone honors that the person living with cognitive loss has an opinion, has a goal, has a value that may not align with everyone else's, but should be honored if possible. And then the last of the 5 themes was that the people lacked confidence in the healthcare setting. And I see why in many times. I mean, having supported my mom through this, they distrust that the clinician has mastery or knowledge of dementia, and that may be true. You may be more the master than they are, and it's okay to educate them. People felt that they were making uninformed choices, that they weren't getting enough information, or that they were deprived of access to hospice care and support at the end of the life. Again, this is part of the reason I wrote these books, is to try to help with this aspect. There's plenty of other resources available. We will continue to offer talks about issues around this at CaringKind. Use your resources so that you feel you're educated in the way you want to be, so that you can make the decisions you'd like to make. I did it again. I clicked inappropriately. And then the last piece of tonight's talk is going to be more about developing and documenting a plan of care for those end-of-life choices. And I just wanted to remind you of that framework, of that the plan is going to change when you're at the beginning until you kind of move to the end. Some plans may not change during that. We talked about that. 10% of people may want the same plan from beginning to end, but this is kind of the continuum we're talking about. And specifically for cognitive loss, there may be another disease when you're living with cognitive loss that supersedes the cognitive loss, but here's this continuum that I'm talking about in dementia. For advanced care planning tools, many of you may have already done some advanced care plans, but you may want to do a little deeper thinking. I'm going to just show you tools that I have vetted that I think are very good. Prepare for Your Care is a very good tool that uses videos and has very good health literacy and cultural literacy, with vignettes about video vignettes to make choices. It's well worth checking out their website. 5 Wishes is another excellent choice because it does more than just medical. It talks about more supportive care that you might want at the end of your life. And then things specifically around dementia. There's Compassion and Choices, has an entire section on dementia values and priority tools that can help walk you through decision making, help guide, as does the Conversation Project. I think both of these are excellent. There's tools in there that might help you talk to your healthcare provider. There's tools that help you talk to family. Again, great places to go for deep dives, and hopefully we'll be doing workshops at CaringKind to use some of these tools a little more hands-on. But I want to talk about where some of those changes. I talked to you about my mom's journey and how we made some changes when she was in the middle stages of her dementia, where we started saying, is this the time to start rethinking medications? So as you're moving through your cognitive changes, you may want to say there's a point where, yes, I've had some of these medicines for a long time, but are they still helping me? Are they a prevention? And I'm moving beyond the point in my life that I need preventive care anymore. I don't have enough of my prognosis is such that I may not live long enough to keep taking medications to prevent things. Nutrition, early on, I definitely recommend, Mediterranean diet of fruit, high fruits and vegetables, whole grains, olive oil for fat, good fats. But as someone is progressing through, if they begin to lose weight and are not enjoying their food, is it time to shift to more eating for pleasure? Or is it time, or maybe not? And is, when is it time to think about when my mom closed her mouth to food? I know that there's literature on when you're not swallowing well, that people thicken food, and the literature is starting to tell us that that is not that beneficial, one, and two, isn't pleasant. That most, like, I know a couple of physicians, a group of palliative care physicians tried to go through a thickened liquid diet and couldn't do it for 2 days even. That it caused more dehydration, that it caused constipation. And so modifications to diet, some are positive, some are negative. Changing exercise. I have a friend who's a physical therapist and has her father, she had him on a treadmill every day, and he was falling often, and he was falling off the treadmill to the point where, I saw him once when he, had an abrasion on his face, and I was like, I understand that you value exercise, but it's time to modify what his exercise is. He can't stay on a treadmill any longer. So those modifications might need to be made. We know that hospitalizations become much more traumatic when somebody may not understand why they're being poked and prodded, and their risk of delirium is going higher. Can what they're being sent to the hospital for be handled in the home setting with enough support, in an assisted living, in the skilled nursing facility? Do they have to be sent to a hospital? Can they be cared for by people who understand their nonverbals? Um, Medical interventions. We talked about that study from the Harvard School of Public Health that said surgeries were happening in 1 in 3 people in the last year of life. Is surgery necessarily the answer, or is it time to really think of a comfort approach? And then engagement versus rest. I've had so many conversations with people about, my mother is not going to the programs. She needs to be woken up and sent to programming. But as we go through dementia, as we go through cognitive loss, our brains need more rest. And if the rest is allowed, a lot of times then for less hours of a day, but there can be better engagement if that rest is there. I know that if my mom had a day that she needed to go see a doctor, or my siblings were coming, and there was a lot of activity, the next day she slept more, and she needed an extra day or two of rest to then have another day of engagement, which was sometimes hard on my siblings when they would come to visit, and she could only be kind of engaged with them every other day. But that was her reality, and sometimes you have to allow for that. And finally, as we move to late stage dementia, what I don't think is out there in our medical community enough, but these are mostly studies out of Susan Mitchell's group at Harvard University, is that when you're in late stage, limiting medical care, not care, but medical care, things like for urinary tract infections and pneumonia and hydration when you can't keep up with hydration, and eating and hospitalizations. These 5 things specifically are not really warranted. And when she's done studies comparing people not receiving these 5 things compared to people who received these 5 things, mostly the people living with late stage dementia who were just given comfort care and not antibiotics for urinary tract infections, not antibiotics for pneumonias, not IV hydration, not a feeding tube, and not hospitalization. The people that did not receive those things had a higher quality of life. The care partners had better outcome. There was less pain, and there was no difference in survival. So limiting some of the medical care and giving comfort care, making sure that pain is well taken care of, making sure that somebody isn't, honestly, antibiotics can cause abdominal pain, and then it can throw or diarrhea or constipation. Hydration can make people fill up with fluid in their lungs, making them more short of breath. There are complications to anything we do medically, and it's not always a good idea to do all the medical care. And finally, one thing I would like to talk about is a more comprehensive advanced care planning in dementia around eating, hand eating, or eating. Many people think that we know that there's a point in the dementia trajectory when someone can no longer feed themselves. And the End of Life Choices New York has developed an advanced care directive for that situation, where you can either choose, there's an option A and an option B. At option A, there are a lot of people who, when they think about dehumanizing treatment, they want to live in their dementia to a degree, but not to the end. And as we know, some people will go to Europe to go through physician-assisted death. In the United States, that isn't allowed. And so you either have to go to another country if that is one of your wishes. But here, we can limit our eating and drinking with an advanced care directive, something like this, where if at the point that you can no longer feed yourself, you can no longer you no longer are able to get food to your own mouth, you can say, I don't want to be fed at that point. That is an option. I don't want you to offer me, I don't want, and then the option B is offer me food. If I take it, great. If I don't, that's okay too. You can offer it to me but don't force feed me. Don't put me on protein supplements. Don't spend an hour and a half making sure I get the right amount of food. It's just, so these are choices that people can make, and put and have them in addition to the typical advanced care plans. So I just want to, I'm going to start wrapping up, and I just want to say this is your life, so it's your choices. You have to remember that you're in charge and that healthcare providers are trained in a medical approach and to save lives, not to create comfort. Um, there are more doctors who are thinking about offering less of the medical approach, but I mean, they're not in the majority. And so I think if you want everything, that's fine. The medical approach will work for you. But if you don't, if you want to be in charge of how you live and then how you die, you are going to have to do some of this looking down the road a bit. You're going to have to look at having some of these conversations. You're going to have to decide, are there positives to dying? And what do I want? What do I want my death to look like? I think I said this the last time. I mean, I think we have one birth and we have one death. We put a lot of thought into birth. We put a lot of joy into it. And I actually think that we should put a little bit of thought into our deaths and how to make them more joyful or more peaceful or more fulfilling. And they can be. Life, the beginning of life and the end of life are time when a lot of stuff falls away. A lot of the trivialities of life fall away, and we can really be thoughtful. And it's nice to put a little of that thought into this. So it's your life and your plans. I highly recommend advanced directives. I highly recommend adding riders to make it comprehensive for those issues about when you might want to change things in the middle, when you might want to change things towards the end. Use the tools that are out there. Use CaringKind, use Conversation Project Toolkit, Compassion and Choices, Prepare for Your Care, the 5 Wishes. Help them guide you. Read them all and see what resonates with you. And then either document or communicate, paper, video, or just conversations with whoever your healthcare proxy may be. But make sure someone knows what you want so that you have a chance to get what you want at the end of your life. And I don't, I love this poem by Emily Dickinson, but I think we are unable are the love to die, for love is immortality. When we base our decisions on values, it isn't as hard, and it makes this easier, and it is the love that stays behind and not the pain or the suffering. There will be grief, no doubt, and we will talk about that in our next part 3, but the love will endure. And so if you need help with any of this, please talk to our navigators. If you'd like to speak with me, here's my contact information. I think this is a good time to put a plug in for the walk because it's coming up and the weather is beautiful still. So here's the information on the walk. And with that, I would be happy to answer any questions.